Okay, selamat tengah hari semua. Saya Dr. Darshini dari Klinik Kesihatan Teluk Intan. Hari ini saya akan present topik saya mengenai CPG Management of Rheumatoid Arthritis. Okay, for introduction, basically rheumatoid arthritis is an autoimmune disease lah, primarily affecting the joint, and the joints are always the small joint first lah. Usually that is the most commonest thing that we see. The joints that are affected most frequently are the wrist, the hand, elbow, shoulders, knee, and then ankles. And it's always symmetrical. That's why we say symmetrical polyarthritis. And it has a variable outcome, variable and unpredictable onset. It can also present with other non-specific symptoms like fever, malaise, fatigue, loss of appetite, and bone destruction of cartilage. And later on, you can see some joint deformity lah, if let's say it's not treated adequately and the treatment is not started at onset of disease. So it's very important for us to detect rheumatoid arthritis as early as possible and start the treatment as early as possible to minimize the disease progression. Okay, this is the algorithm diagnosis for rheumatoid arthritis. How we diagnose? First is we see whether the patient is having inflammatory joint symptom or positive serology. Positive serology here is the rheumatoid factor or anti-citrullinated peptide antibody lah. Okay, when we see that, if let's say patient present with this, and then we see whether there is clinical synovitis present or not. If there is clinical synovitis, then you see whether we have a criteria. We have the ACR or EULAR criteria. Later I'll describe more on this criteria. If the criteria is fulfilled, then probably the possibility of rheumatoid arthritis is high lah. If there is no clinical synovitis present when you see the patient, and you see whether there's any clinical suspicion or not. If you suspect that there's some degree of rheumatoid arthritis, then probably you can proceed with ultrasound of the affected joint and see whether you see synovitis or not. If synovitis detected, then you proceed to look at the criteria whether it's fulfilled or not to diagnose rheumatoid arthritis. If there is no clinical suspicion of RA, you consider other diagnosis and do close monitoring for that arthritis. Okay, this is the algorithm 2. This is the treatment. Treatment, basically, we have a non-pharmacological and pharmacological treatment. For non-pharmacological, what is most important is patient education. A patient must know about their disease, their medications, their lifestyle modification, and of course, we need the help of allied healthcare personnel like of occupational therapists and physiotherapists lah. In a tertiary center, you can find a nurse-led care, which they will assist these patients who are diagnosed with rheumatoid arthritis to go on with their life and to see what outcome. How to help them lah. Besides that, we have another treatment, which is the most important treatment for rheumatoid arthritis, is the pharmacological treatment. The first line is always the conventional disease-modifying anti-rheumatic drugs. Add-on therapies are NSAIDs and corticosteroid, and I'll explain all this further later in my coming slides. Besides the conventional, we have biological and targeted synthetic disease-modifying anti-rheumatic drugs. Okay, clinical feature for rheumatoid arthritis, we have two types, articular and extra-articular. Extra-articular, where patient comes with joint pain and swelling, early morning stiffness lasting more than 30 minutes, symmetrical polyarthritis for at least 6 weeks lah. And then affected joint, like what I said just now. Extra-articular, maybe it can affect the lung, the heart, the eye, the skin, and the blood vessel lah. Some patients with rheumatoid arthritis also associated with other connective tissue disease like fibromyalgia, polymyalgia rheumatica lah. What is important in rheumatoid arthritis? At the same time, patient has increased risk of cardiovascular death and osteoporosis. So this is very important for us to screen them yearly lah. Physical examination, you can see clinical synovitis, what I meant just now in the algorithm, which are the joint tenderness, boggy swelling. Besides that, they have restricted ROM, and as the disease progresses, if it's not adequately treated, patient can develop joint deformities like what is in the picture lah. Boutonniere deformity of the thumb, swan neck deformity, ulnar deviation of the metacarpophalangeal joint lah. Okay, these are the differential diagnosis for rheumatoid arthritis. It can mimic psoriatic arthritis, osteoarthritis, lupus, viral arthritis, reactive arthritis, inflammatory bowel disease, Lyme arthritis, and palindromic rheumatism. Investigation for rheumatoid arthritis, basically there's not much, but what is important is the laboratory and the imaging. Most important is the laboratory investigation lah. Laboratory investigation for diagnosis, what is important, usually we will take ESR, CRP, rheumatoid factor, and what is ACP is anti-citrullinated peptide antibody lah. For comorbid screening and pre-treatment, before we start the treatment, for any comorbidity screening, what is important to do is full blood count, renal profile, liver function test, FBS, FSL, and viral screening for hepatitis and HIV. Treatment, disease activity and monitoring, what we do when after we start the patient on disease modifying anti-rheumatic drug, we monitor the patient with their monitor the FBC, RP, LFT, ESR, CRP lah. This is pre-biological therapy. Some patient we do MEN2, IGRA, HIV screening, immunoglobulin A, immunoglobulin G, AAM, and hepatitis screening. Okay, what is important here I want to highlight is if positive rheumatoid factor does not mean that the patient is having rheumatoid arthritis. Some patient may not have rheumatoid arthritis because it is normal, it's present in normal population with higher incidence in elderly. If negative rheumatoid factor, it doesn't exclude RA, and this is common in 30 to 40 patients of who are seronegative. So we must test RF plus minus with ACPA if there is a clinical suspicion of rheumatoid arthritis. Imaging, not much of entity there, not much of modality that we actually do. Basically, we can do chest x-ray for comorbidity screening, part of TB screening, baseline evaluation before we start the disease modifying anti-rheumatic drug. Hand x-ray, we can do hand x-ray. Hand x-ray is to see soft tissue swelling, justa articular demineralization, joint space narrowing, and bone erosion. These changes are symmetrical and spares the DIP joint. So most commonly is the metacarpophalangeal joint and proximal interphalangeal joint lah. These are the example. What do you see in an x-ray? You can see an AP view of a hand of an early RA. Periarticular osteopenia and soft tissue swelling lah. Like what is mentioned, A is the periarticular osteopenia and B is the soft tissue swelling. Okay, this is the late stage where you can see deformity, hitchhiker's thumb, which is the B, ulnar deviation of the fingers at MCP joint, boutonniere deformity, subchondral cyst, sclerosis, and joint space narrowing. And these are some abnormalities are seen in the PIP, radiocarpal, and intercarpal joints lah. Musculoskeletal ultrasound is useful in early RA with negative ACPA. It can detect clinical synovitis for suspected inflammatory arthritis like rheumatoid arthritis lah. MRI, it's better, it's good, but it's costly and some centers does not have MRI. This is the criteria, which is the ACR or EULAR criteria for rheumatoid arthritis. We need 6 scores to confidently diagnose whether the patient is having rheumatoid arthritis or not. So if let's say more than 10 joints are involved, at least one small joint, you get a 5 points there. 4 to 10 small joints with or without large joints, you get 3 points. Serology, high positive of ACPA, automatically you get about 3 points, or high positive of RA. Acute phase reactants, abnormal CRP or abnormal ESR, you get 1 point. And if the duration is more than 6 weeks of symptom, of course you get another 1 point lah. But patient must have at least one joint of definite clinical synovitis with the criteria to diagnose rheumatoid arthritis. Okay, a score more than 6 is definite rheumatoid arthritis. plus score more than 6, equal 6 or more is definite rheumatoid arthritis, and score less than 6 may fulfill criteria over the time if you see the patient is progressing with the disease. Prognostic factor for rheumatoid arthritis, poor prognostic factor are older age, female, obesity, smoking, positive anti-CCP or ACP, PA, presence of rheumatoid factor, high CRP, high ESR, anemia and high erosion at baseline. Referral: all patients with rheumatoid arthritis must be referred to rheumatologists and must be co-managed by the primary healthcare physician. Indication for referral for diagnosis. For diagnosis, clinical suspicion of RA supported by presence of any more than 3 swollen joint, MCP or MTP joint involvement with positive squeeze test, early morning stiffness for more than 30 minutes. This is referral for diagnosis lah. Referral after the diagnosis is for co-management plan, optimization of therapy and disease-related complication. And some patient must be referred, those who are pregnant, for pre-pregnancy patient, lactation, hepatitis B and C, and malignant and a cancer patient. Treatment: our goal is definitely for pain relief, control of inflammation, preserve joint function and quality of life, and prevent and limit and minimizing complication and managing comorbidities. So, treat to target, shared decision making, define treatment target, assess the disease activity and regular adjustment of treatment. Non-pharmacological treatment basically are education. Educate the patient about the disease, the complication, therapeutic option. Stop smoking. Healthy eating is very important. High fiber, high protein, low sugar, low fat diet. Emotional health, regular screening of their mental health for depression especially. Occupational therapy involving joint strengthening, mobilization, exercise. Advice on joint protection deals with manual activities. Assisted devices. Physiotherapy for TENS and aerobic exercise, and podiatry for proper footwear and foot orthosis. Okay, this is the steps for hand strengthening exercise. If you can see, this is what the physiotherapist will do lah. Because it mostly involves the small joints, so we have to preserve the small joints. These are the type of activities that they do in their clinic lah, to strengthen the hand muscle. Pharmacological, you must initiate as soon as the diagnosis is made. NSAID, corticosteroid and disease-modifying anti-rheumatic drugs. NSAID does not have disease-modifying properties, but it's effective in reducing pain and improving the function. And cautious if the patient is having any renal abnormalities, heart problem. So examples are like the traditional, the cortisone inhibitor lah, like what we know usually, like ibuprofen, diclofenac, meroxicam, Celebrex, Acoxia. Corticosteroid, it's an add-on therapy for your disease-modifying anti-rheumatic drug. Use short-term, less than 3 months, but if you want to give less than 10 mg dose per daily. If you start giving, supplement the patient with vitamin D and calcium to reduce risk of osteoporotic fracture lah. And regular surveillance for infection, because corticosteroid is well known to promote infection. What is most important in rheumatoid arthritis treatment is always the disease-modifying anti-rheumatic drugs. Examples are methotrexate, sulfasalazine, hydroxychloroquine, and leflunomide. They can be used as monotherapy or in combination, and tell the patient that it does not give an immediate effect. It takes 8 weeks to show its effect. So, you need corticosteroid as a bridging therapy. Methotrexate, you can give as subcutaneous, intramuscular, or oral. It's always the first line. Don't forget to give folic acid 5 mg per week to prevent its adverse effect. Contraindicated in pregnancy and lactation, stops 3 months before conception. That's why pre-pregnancy clinic is important for all those who are pregnant, because we want to monitor all the patients on this medication. The side effects are pneumonitis, abnormal liver enzymes, stomatitis, oral ulcer, alopecia, and GI symptom. Sulfasalazine is an oral medication. Side effect: GI symptom, oligospermia, elevated liver enzyme. Compatible in pregnancy with folate supplement. Lactation is safe in full term, but if a preterm cause, if it's G6PD lah. Hydroxychloroquine is also oral. Side effects: retinal disorder. That's why you need to have a baseline eye examination and ophthalmic review. Can use in pregnancy and lactation. Leflunomide, it's an oral medication. Side effect is alopecia, elevated liver enzyme, and allergic. Avoid in pregnancy and lactation. This is target synthetic disease modified anti-rheumatic drug. Tofacitinib, baricitinib, used in patient with resistant first line, unacceptable side effect, and insufficient response for the conventional disease modified anti-rheumatic drug. We have other group, which is the biologic. It's a specifically target to immune cell involved in pathogenesis of rheumatoid arthritis. You use when the conventional one, when the treatment target is not achieved with the conventional one or poor prognostic factor. But what is important is this: it increases the risk of TB reactivation. So before you start, you must do IGRA or MEN2 as a part of latent TB treatment screening. Example: anti-tumor necrosis factor, interleukin-6 receptor blocker, anti-B cell agent. So this is what I said. Before you start with biologic, TB screening is important. Do a MEN2 test or IGRA. If less than 5 mm, no action taken. If MEN2 is more than 5 mm, treat as latent TB. Same goes to IGRA. If positive, treat as latent TB. If negative, no actions are need to be taken. Drug monitoring, basically for conventional drugs, what you need as a baseline is FBC, LFT, RP, hepatitis screening, and chest x-ray. This is similar for most of the conventional drugs. Subsequent follow-up, you do FBC, RP, LFT, AST, ALT with albumin. Frequency of monitoring is 2 to 4 weekly for the first 3 months, or at every dose increase, and then 3 monthly. So if let's say you start this medication and then patient come with neutropenia, total white less than 3.5. Leukopenia, total white less than 3.5. Neutropenia less than 1.6. Raised MCV. Thrombocytopenia, creatinine increased 30%. Abnormal liver function more than 3 times of upper limit. Unexplained reduction albumin less than 30 gram per deciliter. Refer to rheumatologist immediately. This is for target specific. Same thing, mostly are the same blood investigation that you do, but the extra one is that you have to do the TB workup lah. And then subsequent investigation monitoring is similar like the rest. FBC, RP, LFT, AST, and albumin. So frequency of monitoring at week 4, then 3 monthly. Same thing. If you see leukopenia, thrombocytopenia, neutropenia, elevated MCV, elevated liver enzyme, creatinine increase 30%, refer to rheumatologist. This is for biologic, similar baseline investigation and monitoring, but you frequency of monitoring at week 4, then 3 monthly. Traditional medicine for now has insufficient evidence on safety and efficacy. Nurse-led care, what they do, they enhance follow-up, monitor laboratory result, monitor treatment adherence, assessment of disease activity, patient education, healthcare context, hospitalization, and psychosocial support. This one we have in the hospital for all the rheumatology department. Special consideration for those who have comorbidity, those who are going for elective surgery, those who have infection, discontinue the disease-modifying anti-rheumatic drug. Pregnancy and lactation, several medications are contraindicated, so refer them all to pre-pregnancy clinic. During pregnancy, rheumatoid arthritis can worsen, remain same, or improve. Vaccination is recommended. Pneumococcal, influenza, hepatitis B, human papilloma virus, herpes zoster. So killed and conjugate vaccines are safe in this kind of patient. So what is the ACI recommendation? Basically all the vaccines are recommended, except for herpes zoster vaccine. Those who are taking anti-TNF biologic and non-TNF biologics, it's not recommended. Monitoring and follow-up, we must monitor for the side effect, their comorbidities, how's the disease progression. The healthcare must provide understanding. Nurse-led pharmacy counseling is very important for these patients who are having rheumatoid arthritis. Okay, thank you.